Hi, I'm Maxwell Hornig-Rohan, and this is my presentation on tuberculosis for Principles of Epidemiology. The objectives of this presentation are to define tuberculosis and its etiology, to describe the symptoms and methods of identification for the disease, the mechanisms of transmission, the current treatment methods, and methods of prevention. This is the table of contents for this presentation. Mycobacterium tuberculosis. What is tuberculosis? Tuberculosis, or TB, is a bacterial infection caused by M. tuberculosis and other members of the MTB family. While primarily a respiratory infection, its pathogenesis involves the lymphatic system and the immune cells, in which it induces a response, leading to a risk of infection elsewhere in the body. It was discovered to be a bacterium by Robert Koch in 1882, confirming the germ theory of disease. Tuberculosis has infected humans since the rise of the species from early hominids. It has been infecting hominids for the last 3 million years. Prior to the outbreak of SARS-CoV-2, tuberculosis was the most prevalent disease in the world and responsible for more deaths than any other disease in recorded history. It has gone by many names in the past, but was named tuberculosis in the 19th century to describe the abnormal bumps and lesions that occurred in severe untreated disease. Seen here are scanning electron microscopy images of tuberculosis bacilli. Initial infection. Tuberculosis bacilli spread via airborne droplets from a host in an active infection state. Once these droplets land in the lungs of a new host, the TB bacilli invade the alveoli and will enter one of 3 states: gone focus, active and latent. Alveolar macrophages respond to the infection and envelop the bacilli, at which the bacilli either die or infect the immune cell, deploying immunomodulators to signal more immune cells to encase the infected macrophage and provide nutrients for the growth or dormancy of TB bacilli. This is called a gone focus or granuloma and can become large enough to calcify and be seen on an X-ray. In some circumstances, the TB bacilli fails to infect the macrophage and is killed, leading to no formation of granulomas. Because an immune response was orchestrated against TB, cases of this variety will still test positive on a skin test. The background of this slide is a scanning electron microscope image of a macrophage engulfing tuberculosis bacilli. The majority of TB infections are latent. When a granuloma forms, it can go into a state of dormancy where it is being managed by immune cells at the same time as macrophages are being consumed to feed the tuberculosis bacilli. Latent TB infections can be lifelong and typically will not turn into active infections unless the immune system is compromised in some way. This can be from HIV, another type of infection, stress, cancer, aging, at which point the infection progresses to the active stage and the patient becomes infectious. Granulomas can form in other regions of the body during latent infections and will calcify over time. Tuberculosis infections of other organs may show other symptoms beyond the typical respiratory tuberculosis infection. The background of this slide is a slice of tuberculosis bacilli granuloma of the non-necrotizing variety. In the X-ray seen here, the red circled area is a gone focus, indicating a prior or latent tuberculosis infection. Initial symptoms of an active TB infection typically look like coughing that lasts for at least 3 weeks as the granuloma releases TB bacilli and damages the lungs, coughing up of fluids such as phlegm and spots of blood, chest pain, and other symptoms such as fatigue, fever, loss of appetite, chills, night sweats, hoarseness of voice, and weight loss. Keep in mind that active tuberculosis infections in other organs of the body will show other symptoms. These are often difficult to predict, as tuberculosis can land in many different organs. Diagnostic means of tuberculosis identification. One of the primary ways to identify an active tuberculosis infection and also prior infection is radiographic evidence. The presence of gone foci in a chest x-ray. These will be white spots of calcified tissue, often indicating a previous infection, possibly during childhood. And antibody and antigen response. Prior to the development of PCR analysis, a dose of tuberculin, one of the primary antigens of TB, would be injected into the skin. If a reaction formed at the site, this meant that the patient had previously been infected. This is considered ineffective, as anyone who has received a TB vaccine or has also been cleared of a previous TB infection will still test positive in this way. Looking at the levels of antibody and immune cell response in blood can more accurately determine how recently the infection occurred and if it is ongoing. This is also useful to detect latent infections. Nucleic acid amplification test, or NAAT, results. This is the most used means to confirm the presence of active tuberculosis in a case. Sputum or another form of respiratory sample is collected and cultured in a growth medium, and if bacteria grows within 24 hours, as tuberculosis replicates every 20 hours, this is feasible enough, then the NAAT will be sensitive enough to detect it even in extremely small quantities. This is insufficient for accurate treatment, but allows doctors to immediately arrange for quarantine and further testing. The culture must be analyzed later by a less sensitive test that can genotype and identify drug susceptibility. Treatment methods differ based on the drug susceptibility and drug resistance, and also whether or not the case is latent or active. In drug-susceptible cases, latent TB is treated with 3 to 4 months of rifampin and or isoniazid, possibly up to 9 months in immunocompromised patients or those with HIV. In active tuberculosis of the drug-susceptible variety, the treatment regimen is 4 months rifampin, isoniazid, pyrazinamide, and moxifloxacin. In drug-resistant strains of tuberculosis, latent TB is treated with the same regimen as active TB, which is 6 months bedaquiline, pretomanid, and linezolid. Prevention. It is estimated that at least 25% of the world's population has a latent tuberculosis infection. More than 10 million people are suffering active infections every year, and 1.4 million people die from tuberculosis every year. Routine surveillance for immune response to tuberculosis, which would be the only way to detect a latent infection, would be effective at identifying the populations that need treatment to prevent them from ever being at risk. The most effective way to do this would be making it part of annual physicals. Additionally, UVC air filtration in healthcare, workplace, and public indoor areas would help prevent active tuberculosis spread. And as UVC does not discriminate as to what microbe it is killing, this would also help mitigate the spread of other diseases. There should also be further research into drugs that would be better suited to handle latent infections before they can manifest of both the susceptible and drug-resistant varieties of tuberculosis. In summary, tuberculosis is a severe respiratory disease that poses the greatest threat to global human health both in history and in the present day. It has outpaced SARS-CoV-2 in its rate of infection since its resurgence in 2022. However, it is possible to eradicate this disease by preventing its spread. Enhancing global surveillance and enacting treatment programs would make a significant difference in reducing the rate at which people are infected. This should also include investment in further programs to detect latent infections. The faster tuberculosis is eradicated, the less likely it would become fully resistant to the drugs that exist to treat it, or to at least reduce the reservoirs in which a more resistant strain can develop. This would protect the population both in the present and in the future. Thank you all so much for coming to this presentation. I hope you have a wonderful day.